Hello friends, we are going to discuss an approach to a child presenting with hemoptysis. The learning objective is to look at a clinical approach to a child presenting with hemoptysis and the investigative plan. Hemoptysis is expectoration of blood or blood-tinged sputum from the lower respiratory tract. The first question that comes up is it hemoptysis? Because it can be pseudo-hemoptysis, it can be factitious hemoptysis, and if at all it is hemoptysis, then we need to see whether it is a diffuse or a focal bleed and what is the amount of bleeding. Pseudo-hemoptysis is extrapulmonary bleeding. Now this extrapulmonary bleeding may be from the nose, maybe from the tooth, GI, gum. Another difficulty in pediatrics is to differentiate hemoptysis from hematemesis. Hemoptysis is bleeding from the lungs and hematemesis is from the GI tract. There are pointers on history which will help us differentiate between these two. In hemoptysis, the nausea vomiting is absent. The primary disease is lung and asphyxiation is possible. In hematemesis, on the other hand, there is presence of nausea vomiting. The primary disease is either gastric or hepatic and asphyxia is unusual. Sputum examination in hemoptysis will reveal a frothy kind of blood which is bright pink, red, fresh. But in hematemesis, it is rarely frothy and the color is brown to black. The hemoptysis is alkaline in pH, whereas acidic in hematemesis because of gastric acid. And in hemoptysis, it is mixed with macrophages and neutrophils, while in hematemesis, it is mixed with food particles. Now, factitious hemoptysis is a term which is used if no etiology is discernible after a thorough evaluation, especially when the medical history or the patient's behavior is unusual. In such cases, psychological counseling is usually required. But this diagnosis is difficult to make. Now, if you look at pulmonary hemorrhage, we need to differentiate whether the bleed is diffuse, as we can see in the left-sided lung, where the involvement is fairly throughout the lung fields. Or it could be focal, like in the right-sided radiograph, where the pathology is primarily in the left upper zone. Now, if you look at causes of diffuse pulmonary hemorrhage, it could be isolated to the lung only. It may be associated with other disorders or it may be secondary. Isolated pulmonary hemorrhage may be because of idiopathic hemorrhage of infancy. It could be idiopathic pulmonary hemosiderosis. It could be pulmonary capillary hemangiomatosis. It could be lymphangiomatosis or pulmonary alveolar proteinosis. If you look at the conditions associated with other disorders, kidney disorders are associated with hemoptysis in Goodpasture syndrome. There may be nephritis with or without immune complexes like granulomatous polyangiitis, Wegener's granulomatosis, collagen vascular diseases like SLE or rheumatoid arthritis, Henoch-Schönlein purpura, and vasculitic disorders. Other disease conditions are celiac disease, which is uncommonly associated with pulmonary hemosiderosis, also called as Lane-Hamilton syndrome. Pulmonary hemorrhage may be associated with myocarditis. Cow milk allergy or the Heiner syndrome can also present as pulmonary hemorrhage. Premature infants may also have pulmonary hemorrhage. In secondary causes, we have congenital heart disease. In this, the pulmonary hemorrhage is because of either pulmonary hypertension, veno-occlusive disease, or congestive heart failure. Clotting disorders can also present as pulmonary hemorrhage. Then you will have other evidence of bleed also. Malignancies and immunosuppressives can also result in pulmonary hemorrhage. Bone marrow transplant, exogenous toxins, can also present as pulmonary hemorrhage. Diffuse alveolar hemorrhage is also an entity where the involvement is diffuse, can also present as pulmonary hemorrhage. But at times the bleed is so less in amount that it doesn't reach the proximal airways, and usually they present as chronic anemia rather than pulmonary hemorrhage. Then pulmonary hemorrhage may be catamenial, where it is associated with menses. It could be related to trauma also. Now, if you look at focal causes of pulmonary hemorrhage, the cause may be either in the conducting airways or in the lung parenchyma. In the conducting airways, there may be bronchitis, bronchiectasis, airway anomalies, vascular malformations, and foreign bodies, especially chronic foreign bodies, which because of prolonged stay results in a lot of inflammation. In lung parenchyma, pulmonary hemorrhage may be because of trauma. It could be because of pneumonia, infection, and it includes parasitic infection like hydatid cyst. It could be because of infarction, neoplasms, and cavitary lesions. So one should look for clues in history, and if to name a few, if the child is an anticoagulant, that could be the cause. If the pulmonary hemorrhage is associated with menses, think of catamenial. Dyspnea on exertion, fatigue, orthopnea, paroxysmal nocturnal dyspnea, and frothy pink sputum may indicate a cause which is cardiac. Fever or productive cough may indicate pneumonia. HIV immunosuppression can result in pulmonary hemorrhage. A child having chronic lung disease, recurrent lower respiratory tract infection, or cough with copious purulent sputum may indicate bronchiectasis presenting as hemoptysis. Nausea, vomiting, melena, or chronic non-steroidal anti-inflammatory drug use may result in hematemesis rather than hemoptysis. Pleuritic chest pain and cough tenderness may indicate a pulmonary embolism. The next step is to differentiate whether this is a non-massive or a massive hemorrhage. Although there is no uniform definition of massive, if blood loss is more than 8 ml per kg per day or 200 ml every 24 hours, it is massive. Or irrespective of the amount of blood loss, if there is any cardiovascular destabilization, this will be labeled as massive hemoptysis. Causes of massive hemoptysis in pediatrics include bronchiectasis, pulmonary tuberculosis, congenital heart disease, bronchial AV malformations, foreign body aspiration, disseminated intravascular coagulation, bronchial adenomas, cystic fibrosis, and tracheostomy related. Acute lower respiratory tract infection is the most common etiology of hemoptysis in children. And if you look at various reports, almost 31 to 40% of the cases of hemoptysis are because of acute lower respiratory tract infection. Now, although tuberculosis is commonly implicated as a cause of hemoptysis, but if you look at literature, there are a few cases. Some have reported a high prevalence of hemoptysis in tuberculosis. The pathogenesis involves that in pneumonia, the infectious process, which could be necrotizing pneumonia, tuberculosis, lung abscess, or infected bronchiectasis, results in destruction of lung parenchyma. And with the destruction of lung parenchyma, there is erosion of blood vessels which leak blood into the airway, and it is expectorated out as hemoptysis. Bronchiectasis, because of the chronic endobronchial infection and inflammation of the mucosa, results in damaged mucociliary defenses. This results in secretion stasis. The airway secretions are not able to clear out, and because of which the bacterial infection increases. There is increased inflammation and bronchial dilatation. Congenital heart disease can present as pulmonary hemorrhage and cause profuse bleeding. It occurs with pulmonary vascular obstructive diseases or enlarged collateral bronchial circulation. And the cause of bleed in congenital heart disease is erosion of tortuous dilated bronchial artery into the bronchus. And rupture of an atherosclerotic bronchial artery plaque can also result in pulmonary hemorrhage. Localized pulmonary infarction at the bronchopulmonary anastomosis and can also result in pulmonary hemorrhage. In this particular radiograph, you can see a prominent main pulmonary artery indicating pulmonary hypertension. Foreign bodies are an important DD of pediatric hemoptysis, and they result in hemoptysis because of mechanical trauma to the respiratory epithelium or the ensuing inflammatory reaction. And few reports have reported it as a common etiology for hemoptysis. Cystic fibrosis, very common in Western countries, and 5% of cystic fibrosis present as massive hemoptysis due to the underlying bronchiectasis. In one of the studies, it contributed to 65% cases of pediatric hemoptysis. In cystic fibrosis associated hemoptysis, the hospitalization is longer, and the reason is various comorbidities associated with cystic fibrosis. In cystic fibrosis, the underlying pathology is chronic inflammation, which results in hyperplasia, tortuosity, and dilatation of the bronchial arteries. This results in erosion of these dilated thin bronchial vessels, resulting in hemorrhage. Aspergillus infection. It can be invasive aspergillosis or allergic bronchopulmonary aspergillosis. This can also present as hemoptysis. Neoplasms are a rare cause of hemoptysis in children, but they can cause massive bleed. Tumors which are associated with hemoptysis are bronchial carcinoid, bronchial adenoma, endobronchial metastasis, mediastinal teratomas, tracheal tumors, or bronchial AV malformations. Hemoptysis is a well-recognized complication of long-term tracheostomies. Massive bleeding can occur in approximately 10% of the patients. Idiopathic pulmonary hemosiderosis is the rare cause of diffuse alveolar hemorrhage. The etiology is unknown, and it is more frequent in children. The history of idiopathic pulmonary hemosiderosis is variable, and there are repetitive episodes, and at least the initial studies have indicated that there is a high mortality. They present more as iron deficiency anemia, secondary to the deposition of hemosiderin iron in the alveoli. Investigations should include a complete blood count and coagulation studies, and a urine examination also for any microscopic bleed if there is no gross hematuria. Then a sputum examination can be done to look for a microbiological evidence of any infection. And if it is there, its culture sensitivity. Sputum can indicate hemocytin-laden macrophages, which will indicate that the blood has reached into the alveoli. After that, chest radiograph, computed tomography, bronchoscopy or angiography may be required, and the studies should be done more or less in this order, proceeding from the less invasive ones to the more invasive ones. Chest radiograph can help us differentiate whether this hemoptysis is because of a diffuse lung disease or a focal lung disease, but in 1/3 of the cases chest radiograph is normal. Computed tomography. Contrast studies can differentiate vascular and solid structures. HRCT is the most accurate and sensitive non-invasive diagnostic tool for evaluation of bronchiectasis. Now, if you look at role of bronchoscopy, rigid bronchoscopes are used for suctioning of clotted blood. And the advantage with a rigid scope vis-a-vis a fiber optic bronchoscope is that with a rigid scope, you have a better control of ventilation. Fiber optic bronchoscopes can help us identify lesions in distal bronchial tree. But with a fiber optic bronchoscope, the ventilation is poorly controlled and it is difficult to suction clotted blood with a fiber optic bronchoscope. But the diagnostic yield of bronchoscopy is 40 to 100%. If the bleed is recurrent or massive, then one may have to do a angiography to identify an AV malformation, and depending on that you can treat that. If the hemoptysis is unexplained by a pulmonary cause, even in the absence of overt cardiac symptoms, an echocardiography should be done. Thank you for watching this video. Please help us improve the content by commenting in the comment section or emailing at the link given below, especially regarding the length of this video, anything which can be removed or anything which can be added, or any other comment and suggestion. Thank you so much.